Frost with Celebration Magazine Live, and today we have a special Zoom and Learn with WellMed. Now we are being joined by Dr. Megan Connolly, who is going to speak about routine health maintenance and how much it can make a difference in your overall health. We have 49 people registered for today, which is amazing. And as always, please make sure if you are with us in the Zoom, you can put any of those questions in the chat box for us. That being said, I am going to turn this over to Dr. Connolly, and she can take over the show.
Buddy. Oh, I got to unmute. I had a double mute situation going on here. Hi, everyone. Thanks for having me today. Hope you enjoy my snowy background. It feels very Christmassy to me. It puts me in the Christmas mood. I want to introduce myself real quick. I recognize some faces and names from last time I came and talked to you guys. My name is Megan Connolly. I'm double board certified, actually, internal medicine and in pediatrics. But at this point in my career, I've just been practicing internal medicine. I see mostly Medicare and Medicare Advantage patients in the Dallas-Fort Worth area, in Las Colinas to be specific. I am excited to talk to you today about health maintenance. It is really important to get routine care. And we're going to dive into what sounds like, even when I started writing the presentation, I was like, okay, we're talking about this, and oh, wait about this. It becomes more of a big, complex issue than you would think just going in for a normal checkup. So I am going to share my screen real quick. Give me just a minute, and then here we go. Here we go. And pull this up. Zoe, are you watching the chat, or do I need to keep an eye on the chat?
I will keep an eye on the chat for you.
Awesome. Thank you so much.
You're welcome.
Okay, so without further ado, this is a picture of me and my family in one of our favorite places to go, Lake Tahoe. We were there at Christmas last year, me and my 3 kids. Having a good time. For Christmas, what I wanted was family pictures because, you know, mom always wants family pictures, but nobody else does. Oh, mom, okay. So a rare event, we got a family picture that's not too old. So when you talk about health maintenance, this is when your patients are coming in and they're coming for a routine well visit. And this means that you're not coming in because you have a new symptom, you have a specific question or concern. Now, certainly sometimes people come in for their regular visit, their regular annual checkup, and it's a quote unquote well visit, but they have some questions and things going on, which is perfectly normal, happens all the time. But from a perspective of a physician or from a clinician, when someone comes in for an annual checkup, there's this whole list of things that need to be taken care of on a regular basis to make sure that we're not letting anything slip through the cracks. And the things that we consider are these you can see on the screen are the age of the patient, the gender, the family history and any known genetics, the ethnicity, the social history, and the environment. All those things come into play when you start talking about things that you want to prevent or detect early or try to help manage down the road. So we're going to dive into each one of these things. So this is Father Time's influence. When you're looking at the age, and you can find where you are on this little chart. You don't have to share. We're not going to put anybody on the spot today because I don't want to share where I am on this chart. We won't spend too much time in the childhood years, but I think we're all familiar. Newborns are clearly things that we, as a pediatrician, we screen for in the immediate newborn period. There's known nutritional deficiencies. All babies are vitamin K deficient when they're born, so they all get a vitamin K shot. We do newborn screening for rare metabolic and congenital abnormalities that not common, but if you make nutritional changes early on in life, can have a huge impact down the road, and those are screened for early on. Obviously, there's nothing better than a good physical exam, looking for normal development and things like that. And then throughout the childhood years, watching the growth, watching the development, watching for endocrinologic or orthopedic or any kind of disorders that can disrupt the normal growth and development. In the young adult years, 18 to 40, which tends to be a generally healthy time period for the majority of people. Obviously, that's not the case for everyone, but there are not as much risk in that period. So really this age category, we focus on monitoring and counseling safe social habits. When you drive, do you text? Do you wear your seatbelt? If you drink, don't drink and drive. How much do you drink? Do you use illegal substance or illicit substances? When you're using these substances, if you use them, are you driving? Are you doing unsafe behaviors? We do intermittent screening. So if you between 18 and 40, typically we'll do blood work for cholesterol and blood sugar and diabetes. The recommendation is to do that as a very broad generalization every 3 to 5 years in this age group. But then that all depends on any family history, any big changes, any new symptoms that develop, things like that that may influence you to screen them sooner. But the times that we do those blood screenings are more spread out because of that. And then, of course, every age group has age-appropriate screenings. Flu vaccine we recommend every year. Nice little plug here, get your flu vaccine. Tetanus is a vaccine that we now combine with whooping cough, and we boost that one every 10 years. HPV is given between ages 9 and 27 to prevent cervical cancer. And there are some illnesses that we give pneumonia vaccine in this age group. If you have asthma, if you're a smoker, if you have known kidney disease, things like that, then we would do pneumonia vaccines at an earlier stage. Between 40 and 50, we start to do some earlier screenings for early cancer detection. We continue to do the 18 to 40-year-old screenings. For women, I didn't even mention this, but for women at 21 and up, that's when we start to do cervical cancer screening with pap smears, breast self-exams for breast cancer. At between 40 and 50, annual mammography, we start to recommend for women. Earlier, if there's a strong family history, and actually if there's a really strong family history or a known genetic component, then we would actually recommend annual breast MRI, depending on the exact situation there. Between 40 and 50, we are more likely to see things like thyroid disorders, diabetes or prediabetes, and cholesterol things. And some of these come because between 40 and 50, we tend to get a little less sedentary than we were when we were 20 and 25, and might have some changes in our activity levels and our diet and whatnot. But also as we get older, some of those genetic predispositions that maybe weren't loud and proud in our early years, they start to rear their ugly head as we get older. And so looking for things like diabetes, cholesterol problems. We do screen for kidney disease because it's not super uncommon to see. And then we continue to give age-appropriate vaccines in this age group as well. At 50, some of the screening, this is when really the screenings start to be much more significant. Between 50 and 65, we start to see where, you know, our genes aren't meant to last forever. Our bodies, unfortunately, aren't meant to last forever. And so you start to be more prone to infection. We start to watch for cancers more frequently because this is when they're going to show up. And so we'll continue to do the screenings between 18 and 50 that are appropriate, and counseling regarding, again, none of these are black and white only in this age group. There's a lot of continuum here. Somebody who is drinking at 40 is entirely possible to be drinking at 60, and we're still going to talk about those things. But we start screening for colon cancer. We start screening for prostate cancer. We definitely do regular metabolic screenings for cholesterol and diabetes and kidney function, thyroid, and things like that. The one vaccine that's recommended starting at 50 is the new shingles vaccine called Shingrix. If you had a shingles vaccine within the past 10 to 15 years, you probably had one called Zostavax that was several years ago, and it was not a great vaccine. It was better than nothing, but it wasn't fabulous. And Shingrix, the reason we are revaccinating people is that it's a much more effective vaccine. It works better and it lasts longer. So you may have heard about those two different vaccines, and there's can be some confusion because Zostavax was recommended starting at age 60. Shingrix is recommended at age 50. And the reason they bumped that back is because it lasts longer and you get more of a protective effect. And you also do see an increased risk for developing shingles starting around age 50. At 65 plus years, really a lot of the screenings and health maintenance that we do becomes a shared decision-making conversation. And that's really talking to patients individually and really looking where are you in where are you in your health and your life overall. For someone who is 70 years old and still goes jogging and still takes trips and is super active, we're going to continue being active to screen for things that can help detect cancers early because they'll be lower risk for surgeries because they're healthy. We're going to continue to try to prevent infections because they're out and about doing things. Certainly by 65, some people have acquired some significant medical problems that would lead us to believe a life expectancy might not be as long as anticipated. And whether that's a dementia onset, we've already had a cancer diagnosis, then we start having conversations. Do you want to keep screening for these things? Do you want to keep having mammograms? Do you want to keep having colon cancer screenings? After 65, most women don't have pap smears anymore. And that's just because the rate of cervical cancer goes way down in that age group. So this becomes very individual specific in this age group, where you really want to talk with your physician or your provider about what things really are going to be of benefit to you and what things you might be able to lay by the wayside unless symptoms develop. Any questions about, this is a busy slide, so any questions about this slide before I go on to the next one?
So far, so good, Dr. Connolly.
All right, awesome. All right, battle of the sexes, gender-specific conditions. And I think we're all pretty aware of these. This one slide won't take as long as the last one. But obviously in women, we're gonna be screening for cervical cancer, breast cancer. We're gonna do osteoporosis prevention and screening. In males, we're gonna be doing prostate cancer screening, testicular cancer screening, heart disease prevention screening. And that doesn't mean we don't do heart disease prevention screening in women, but being men are much more likely to develop coronary artery disease as they age. And so it's something that we will screen for earlier on and with more minimal symptoms because of that predisposition. And then hernia screening, just because of the structural anatomy of the male body, are more prone to hernias. The thing with cancer screening is that cancers don't really hurt until they're big. And so if you wait until you have symptoms, you've really kind of let the horse out of the barn or the cat out of the bag, whichever metaphor you want to go with there. And so the purpose of early screening for cancer is to find it before you ever have a symptom. So hopefully it's limited to the organ where it started and it hasn't spread anywhere. And so therefore treatment becomes much more simple. You take the cancer out and you're done. There's not any additional chemotherapy. There may or may not be radiation depending on the organ and the site and things like that, but it really is a much simpler treatment plan with a much better outcome for patients. Colon cancer is one that we have this conversation a lot. And as you can imagine, not a lot of people like to have colonoscopies. It's not a fun idea. The procedure's not that bad. You kind of get knocked out, but the day before is not fun, drinking that stuff to clean you out. But the abdomen is a really a place where things can grow and change and become rather large before you ever would have any symptoms. And I liken this to patients when I have this conversation is think about a woman who's newly pregnant. It takes 5 months for really the general public to know that she's got a bump and see that there's a baby growing and that she is pregnant. So if you have a colon cancer that's growing in your pelvis or your abdomen, it can grow quite large before you ever have a symptom, whether it changes your bowel habits or shows blood or causes fever or weight loss. And so even though it's the most invasive cancer screening we have, it's important to still do because it is the one that can hide out the most. So that's just a little blurb on that one because it's a bigger procedure than a mammogram or a pap smear or a prostate exam or something like that. So let's talk about genetic and family history. This is where you really do get to blame your parents because these are the things they pass on to you. Sometimes they're new genetic things. I mean, our genes change with every generation, and you can have new changes to the genetic code. But this is where we look at family history to see if there's anything that we know could be in that the genetic code that we want to watch for. So if there are known genetic conditions, some people come in and they say, well, I know that my dad has polycystic kidney disease. That's a known genetic autosomal dominant condition that can very easily be transmitted to progeny. And so we would screen for that. Cystic fibrosis, sickle cell disease, or sickle cell trait. So these are things people come in and they usually know these and they can tell you, and then you're going to do appropriate screening depending on the age and what the condition is. Family history of cancers. There are cancers that run in groups and tend to have a familial pattern to them. Breast, ovarian, and colon tend to be one of those that cluster together. Some of those you'll find to be BRCA positive, if you guys have heard about the BRCA testing, but not all families that have this cluster of malignancies in their family line are BRCA positive. So clearly there's other genes that have yet to be identified. They're playing a role in these familiar patterns. Prostate cancer has a familial pattern, and honestly, any frequent cancer. So I have a friend and who's also a patient, and her family just has a ton of stomach cancer, which is not common in the U.S. You move to Japan, yes, but in the U.S. it's not. And so we don't have a gene we can screen for or hang our hat on, but she gets very frequent endoscopies where they take a look, and she takes Nexium all the time to help prevent that malignancy. And so anywhere time you see a family where there's a frequent cancer, whether you know of a familial trait or not, you're still going to be more on the lookout for that. Family history of cardiovascular disease. Obviously, cardiovascular disease can run in families. What we particularly look for is a history of premature heart disease. Here it is. So in a male, if you have heart disease at a younger than the age of 55, that's considered premature, and there's likely to be more of a genetic component to it. In females, if you develop heart disease younger than 65, then we would assume there's a genetic or familial component to that. We would start screening sooner and be more concerned if a patient were to develop symptoms that sounded like heart disease, chest pressure, tightness, mostly with exertion, radiating to the left shoulder, arm, things like that. Psychiatric illness is one of that definitely runs in families. And I'll tell you, psychiatry is a field that is just booming with research right now. The brain is by far and away the most complex organ we have. And we know just the tip of the iceberg about the brain and how it functions. But we know very, very clearly that things like depression, anxiety, bipolar disorder, predisposition to substance abuse, and suicide are all things that run in family histories, in family lines. And so that's a part of a history I take on all my patients, because I'm going to screen for these more aggressively if I see them in the family history. And then family history of metabolic disorders, diabetes, thyroid disease, familial hypercholesterolemia. These are things that definitely run in families and we would screen. If there's really strong family histories for some of these conditions, we actually start screening at a younger age. So if you have a family history of multiple people with breast cancer in their 40s, you're not going to wait till 40 for your first mammogram. You're probably going to have one at 30 or 35. If you have a strong family history of colon cancer in a younger age, you might not wait till 50 to do colonoscopies. And the age is what a general rule of thumb, very general, is that you're going to start screening for that cancer 10 years earlier than the youngest family member that has had that repeated cancer in the family line. That's not the same for each and every one, but it's a general rule of thumb that stands for most of them. Any questions? Should I break here for a minute or?
Yeah, so we did have one question asked about what about having the full body scans?
So the full body scan is one of those things that it sounds really fabulous and glitzy and whatnot. Full body scans have not been adopted by the general medical community for a couple of reasons. One is it's a lot of radiation, and radiation does increase your risk for future cancers if you get lots of exposure to it. And so doing testing that's not needed is definitely an exposure you wouldn't want. The other thing is when you look at studies of people who have full body scans, they tend to find things that are incidental. And what that means is nobody's body is completely symmetric. Nobody's body is completely perfect. And so you get a full body scan, you find something somewhere that now makes you nervous and worried. And now you have to go figure out, is this something I need to worry about or not? And so you have some more tests and you have maybe a procedure, you not have a biopsy. And by and large, those full body scans tend to lead to anxiety and worry about things that are not relevant. Has everybody heard a story here and there about somebody had a full body scan and detected something early? You can pull out one of those 1 in a million kind of stories to hear them, but the vast majority of people find things that lead to other procedures and other risks with those procedures that really end up meaning not a whole lot of anything. And so really doing the recommendations that I'm presenting here are all recommended by the American Cancer Society, the American Diabetes Association, the American Heart Association. These are all vetted, peer-reviewed recommendations that the risk of the screening the benefit of the screening outweighs the risk. And this is why these organizations and governing bodies really recommend that we do these regularly. Does that make sense? Answer the question?
Makes a lot of sense, actually. I never even thought about the exposure from the radiation, just of doing that. Makes a lot of sense. All right, we do have one other question that popped up here before we move on. With the new, especially with the new shingles vaccine, do you need to quarantine at all after receiving the vaccine?
No, you don't. The old shingles vaccine was what we call a live attenuated vaccine. And so it was a live virus that had the infectivity components on the surface of the viral particle taken off, but you could sometimes occasionally see a mild case of it, in which case you didn't want to be around other people that could catch it. But the new one, the Shingrix vaccine, is not a live vaccine, it's a killed vaccine. And so you're just getting chopped up pieces and parts of the virus that are making your body, kind of tricking your body into thinking you have shingles. So it's going to mount a response to it that it can then remember later on if you actually truly have shingles. So with the new one, you don't have to quarantine at all. You don't have to limit exposure.
Fantastic. All right. We're ready to move on.
All right, let's do it. So ethnicity, where you come from. Obviously, this is a huge genetic component of our makeup, and you can see different conditions that are clustered in different populations. And these are just a few examples. Obviously, this is not an exhaustive list at all, but these are ones that most people will recognize and are fairly commonly known. So in the African American population, we screen more for sickle cell disease. Prostate cancer tends to occur earlier and be more aggressive. And so we actually screen African American men starting at 45 instead of 50 for prostate cancer. And hypertension in the African American population tends to be more, it's harder to control and it's higher association with kidney disease. And so we screen for it just as regularly, but we're quicker to treat it and be watching those kidneys very closely for this population that develops hypertension. I mentioned Japan and stomach cancer. It's an interesting one because nobody's really ever been able to put their finger on what's causing it. There's not been a gene identified. There's not a dietary contributor that anyone's ever found. But stomach cancer is by far much more common in Japan than is in any other country in the world. There are certain Jewish populations that are known to have certain metabolic disorders that can cause problems with medication interactions. Hispanic population is more vulnerable to diabetes, and the Middle Eastern populations are more vulnerable to diabetes and high cholesterol. So that definitely comes into play on our screenings and how often we do screenings and health monitoring type testing. Let's talk about social history, the party part. This is all that stuff out there that can be a whole lot of fun. It's done in moderation, but if you do too much of it, it can cause big problems. And so any part of a good history of a new patient or an existing patient on a regular annual visit is to ask if you weren't smoking before, are you smoking now? If you were smoking before, have you stopped? Talking about the impact that smoking can have on the body. And most people are well aware of the pulmonary effects, the higher risk of COPD and emphysema, and higher risk of lung cancer. But tobacco and nicotine, because it goes throughout the body, is actually significantly associated with increased risk for cardiovascular disease. That's heart disease, that's stroke, that's circulatory problems. It's also associated with urinary cancers because the metabolites of the nicotine and tobacco that you smoke will go through the kidneys and sit in the bladder and can irritate the lining of that system and cause irregular growth patterns. And then the head and neck cancers in the throat and the pharynx, the back of the throat, cancers are increased there as well. And you have to always remember, you can ask patients, do you smoke? And they'll say no, but then you find out a couple of years later, oh, but I chew tobacco all the time. When they're much more at risk for oral cancers that you need to be aware of. Alcohol, very one that's very commonly known. Moderation is okay, but in excess causes all kinds of problems. And I didn't, multi-system illness, I didn't even start to put the list in there. It can cause bone marrow suppression. It can cause liver disease. It can cause stomach ulcers. It can cause esophageal stomach cancers. In combination with tobacco, interestingly, the head and neck cancer rate is exponential. So if you smoke and you drink heavily, your risk for head and neck cancer is not just 1 + 1 is 2. It's kind of like 1 + 1 is 4. The two of them act in a way that really multiplies the effects. We always screen for illegal substance use and screen for dependencies because that obviously impacts people's health in a lot of different ways and impacts unsafe behaviors. If they're driving when they do things, if they're making bad decisions about sexual activity or things like that when they're under the influence of substances. IV drug use specifically, we screen for HIV and hepatitis because of the potential exposure there. And then sexual activity screening when we screen for sexually transmitted infections. All right, and then environment, which gets a lot of hype in the media. Definitely there are environmental concerns that can contribute, things that you would want to look at in a routine, regular physical as far from a health maintenance perspective. It doesn't play quite as much of a role as sometimes it gets in the media gives it. But if you're living in a tropical area, the infection risks that you'd want to know are familiar or endemic to the area. Malaria is probably the biggest one worldwide that you need to know where it exists and where you'd be at potential risk for it. For patients who live in the DFW area, we have a very ethnically diverse population, and they do a lot of worldwide traveling. And so I do a lot of consultations and patients come in saying, hey, I'm traveling here. What do I need to know? Do I need any vaccines? Do I need malaria medication? And the CDC has great resources for looking those things up. I mentioned the risk for stomach cancers in Japan. There's a much higher risk for hematologic cancers in Russia, where they had the Chernobyl incident several years ago. And then depending on in third world countries, lots of more nutritional risks that patients face. And if I see this one more in adoptions. If I'm seeing a family where they've brought in, and like I said, I don't do much pediatrics anymore, but if they're bringing in children from adoption, screening for these kinds of things. And then if you have small isolated communities where you have, this is going to sound crazy, but you know, a cousin marrying a second cousin, or it's just not a very close knit community and not a lot of interaction with other ethnicities, you're going to see more congenital genetic abnormalities. And that's what I've got for you guys today. I know I threw a lot of information at you all at once. I think a lot of it's fairly familiar. So just to kind of put a structure and a framework to it, I think is helpful to know how we come about with these decisions and the tests that we recommend that you do. So we've got time for discussion, time for questions, and I'm ready to hear what you got for me.
All right, I was talking away and you weren't hearing a thing because I was muted. So I do the same thing all the time. I forget that I mute myself. Okay, so I'm gonna ask this question. Why was for ethnicity that it was Jewish and not Western Europe or Eastern European? Is there I think you talked about, when you were talking about the disease processes involved with different cultures. So
there's a subpopulation of Jewish ethnicity called Ashkenazi Jewish population, and it has to do with historically a part of geographically where they came from, or just, I guess not geographically because there's been lots of dispersion, but it's the heritage that comes from that line that tends to have more, and they tend to marry within their same population. And so they have a higher risk for like G6PD deficiency, which is an enzymatic deficiency in the red blood cell that can interact with medications really badly. It can interact with some certain foods that you have to counsel those patients, hey, you cannot eat these things because it will cause hemolysis. So that's why not general Eastern European. It's really a subset of that ethnicity. Good question.
Interesting. That is a great question. Okay. All right. So this is a tough question to answer, but I know you're going to do it. Is where are you located? And do you take Medicare Advantage, WellMed True Choice Insurance? There we go. I got it.
I do. I am located in North Irving and Las Colinas area, and I take all Medicare, but I prefer Medicare Advantage because I think they do a much better job supporting their patients, and they have more benefits to patients. And I am taking new patients. Yes.
Okay, well, there you go. And then you can also find the locations on their website, but if you specifically need the information of where to find Dr. Connolly, we'll get that information out to you because you'll be able to send that through the contact. Okay, so here, this is an interesting question. What is it that some genetic diseases skip a generation?
So typically those types of genetic diseases tend to be X or Y linked. So they're connected to the genes that determine gender. Mm-hmm. And you're going to see a differentiation there. There are some things that are said they skip a generation and they don't really. It's just because they're so intermittently expressed or transmitted that you may not see it in every generation. Like you might have a parent who has an illness, their child is a carrier but doesn't have the illness, but then that child marries someone else who's a carrier, so then their kids have it. And so some of that has to do with just the penetrance of the genetic defect in how it manifests.
And wouldn't part of that too also be, every time someone comes in, you're adding 50, you're adding someone else's genetics that could cancel that out kind of thing. Like you get a whole new cocktail, right?
Well, and then you add to that, you have spontaneous mutations, right? Because not every time someone gets pregnant do those genes split perfectly, and there's different things in the environment or medications or exposures that can make changes there as well. So it's an amazing process.
Yeah, it is. Okay. So someone recently had their annual physical and their physician did not mention the new shingles vaccine. Do you feel that they should talk to them about this?
If you're over 50, yes. And you have questions, absolutely. I'll tell you that this year has been a little bit hard. There's so many things flying at providers with COVID, and the recommendations change almost by the minute, if not by the week. It's slowed down a little bit since the beginning. And there's so much to cover in a health maintenance. There are times that I miss shingles on one visit, but then I say it the next year. But yes, absolutely, that's something you should ask about.
Great. What would be some symptoms for colon or stomach cancer?
Sure. So they tend to be fairly vague because the abdomen has the ability to compensate so much. So it tends to be vague, fatigue, weight loss without trying to. You can have some blood in the stool. But see, the thing is, if you wait for symptoms, cancer is very slow growing and it hides so long that it's usually fairly advanced once you have symptoms. But they tend to be related to the anemia. So it's the fatigue. You can have any kind of cancer that's hidden that you don't know of, can cause some sporadic fevers that you don't really know what they're coming from, can cause weight loss that's unexplained. I always ask people, have you had any unexplained weight loss? And they say, oh, I wish. No, you don't want it that way, I promise. You want to earn it.
Okay. All right. So Dr. Connolly did put her office number here in chat if you were interested in that information. Oh, wow. This is interesting. Wow, Barbara. So, okay, I gotta say, Barbara Russ said that she has family members that have lived long lives, 1 to 102 and 1 to 104. And is this something that is hereditary?
So you've got some great genes there. Yes. Now, did you get those same genes that can help you to live that long? Hard to say, but it certainly gives you some better odds at living longer.
Fantastic. All right. Parkinson's. Does Parkinson's disease have a family connection?
Not that I'm aware of. I haven't looked that up in several years because I haven't had a patient with it in a while, but last I read and looked, they've not identified a connection.
Wow. Wow. Okay. Okay. Is the new shingles vaccine 2 shots now instead of just 1? So there is a booster, right? Got it. Okay.
Yep, you get a booster 2 to 6 months later.
Okay, perfect. And then I don't know if you can speak to this or not, but why is the copay so high for the shingles vaccine?
I don't know. I'm sorry. A lot of different plans have different benefits and cover different amounts. I know that one tends to be more expensive, and I can't fathom why, because if you get bad shingles and have post-shingles nerve damage, it can be very expensive to care ongoing. But I'm sorry, I don't have a good answer for that one.
Yeah. So I see in a direct message that I received, definitely importance of your shingles vaccine. Someone told me that they had shingles on the one side of their face and that they still have nerve damage from it. And that since they've had their vaccines, they haven't had any problems since then. So, okay.
And the older we get, the more prone we are to shingles and the more prone we are to having more severe shingles and the permanent damage that you can see from it.
Mm-hmm, mm-hmm. All right, we got questions pouring in, Dr. Connolly, so we're going to try and get through these. And also too, I can always put these questions together, send them to you if you're willing to answer them after the fact, and you can email them out.
Sure.
I can save them all. So if someone has blood in their urine and it isn't cancer, what else could it possibly be?
So the things that I would think of first off would be either a kidney stone that you may not be symptomatic from if it's just hanging out there in the kidney and isn't trying to pass. Could be an infection. Those would be the things I'd think of first off. And those 3 would be the top 3 things that blood and urine would be.
Yeah, kidney stone was the first thing that came to my mind. All right. So we did have someone ask, and I'm surprised this is the first that it's come up, but do you recommend the new COVID-19 vaccine for people over the age of 65?
100%. And the only thing I would say is right now with the things that the patients we've seen that have had significant allergic reactions, if you've ever had a history of an anaphylactic reaction, I would hold off for a little while until we have some more data. But that would be the only reason I would say hold off. Other than that, yes, go get it. Fantastic.
All righty. And if you had the shingles vaccine several years ago, do you need to get it again?
It depends on which one you had. If you had Zostavax, which is the older vaccine, then yes, you should get it again. If you have had Shingrix, which is the newer one, and you had both doses, you do not need to have that again. If you only had 1 dose, then you should go back and get the second booster dose.
Perfect. I think I'm going to make sure my mom knows about that because she had the old one and it did not work for her and she gets shingles terrible. So I think I'm going to make sure she knows about the new one. Hopefully that'll help her. We made it through our questions. Yay!
Awesome. Those were really good questions.
Yeah, they were fantastic questions. Real quick, before we unmute and give our round of praise. I want to bring up, I'm going to add Jasmine. I'm going to put you on the screen because I want you all to get to know her. So Jasmine is kind of our local rep, the person that I work with through WellMed. And when it's safe again, she might be the person you see out at events. So I just wanted you, Jasmine, say hi, unmute yourself, say hi.
Hello, everyone. Nice to virtually meet you. Hopefully, I will be able to come see you guys in person soon. So, but it's very good to finally see some faces.
Right? I agree. I can't wait. I'm all excited for the vaccine.
I know.
Then I can we can have parties here again.
I can't wait. I heard you guys are so fun, so I can't wait.
Oh gosh. Oh my gosh.
Thank you.
All right. Well, thank you. Everybody unmute. Let's give Dr. Connolly a really quick round of applause. We do need to let her go.
Thank
We
you.
appreciate you joining us today.